You're listening to In the Thick of It, a podcast from the HCM Society, where we interview experts in the hypertrophic cardiomyopathy field to broaden the awareness of new HCM studies and advancements.
Please enjoy today's discussion supported by an unrestricted educational grant from Cytokinetics.
How can echocardiographers improve the detection and assessment of hypertrophic cardiomyopathy? On today's episode, Dr. Amy Dillenbeck and Dr. Brad Mehl break down the challenges of identifying HCM using echocardiography, discussing best practices for image acquisition, optimizing Doppler techniques, and utilizing advanced tools like contrast imaging. They also explore strategies for training sonographers to recognize key HCM features and avoid common pitfalls in diagnosis. Tune in for a practical discussion on enhancing echocardiographic accuracy and confidence in HCM evaluation. Let's get in the thick of it. Here's Dr. Amy Dillenbeck and Dr. Brad Mehl.
The first question I want to kind of pose to you, Brad, I know that it's challenging. I know you've lived this for a long time, is how do you train your sonographers at your site to become HCM competent?
Oh, it's a great question. Very challenging. First, we need to diagnose it. That's the first and foremost. We start by education, by giving our sonographers some education on the different types of hypertrophic cardiomyopathies, the potentials, how to assess it once you do find it. We are fortunate we have a great educator here, and we have great leadership that very experienced sonographers. So if we have a case, we're typically teaming up and making sure the staff are aware, they know how to assess it. We review the cases afterwards, what we could have done better, what were great things, teach them some tricks like coming off the traditional views to get the gradients, on some of those outflow obstructions, and of course the use of image enhancer to really identify those more apical hypertrophy cases that you may miss easily.
Yeah, I mean, I think that's a great point you mentioned about the team approach. I think using resources you have with educators and staff and, sonographer experts that feel really comfortable with HCM is really a goal for those that are starting off. I would say I could be wrong, but I feel like if you ask 10 sonographers what the worst pathology is or the most scary pathology to work up, probably 8 of those 10 would probably say HCM. And I think part of that is a lack of knowledge. Maybe just it's a little intimidating because not a lot of experience with HCM. And so I think it's really important to have those resources to be able to use appropriately. So that's a great point. I think also we like to use at our center kind of a one-on-one approach, like you were mentioning, where you would have someone do that echo. You would kind of help them assess what the needs are, what we need to do. If we know there's a history of HCM or they're looking for HCM or have some of the symptoms like syncope, something like that. And so I think a lot of the education there, if you have one-on-one and you can sort of have an approach where you have that senior sonographer that feels comfortable really be able to mentor that junior sonographer or someone who doesn't feel comfortable, I think that's a really nice model as well.
I agree. You hit a good point there is history. Listening to your patients. We're finding a lot of patients who have been misdiagnosed. Talking to your patient, they're short of breath. If they can't walk very far, ask them questions, kind of dig in a little bit deeper to your patients and ask them, what were you doing a year ago? And some say, well, I'm just getting older. That's usually not a good excuse. There's a reason why they're short of breath, and really take the time to use the tools we have in our tool belt to make sure we're looking at every part of the heart to exclude this diagnosis.
And that's the great thing when you mentioned like all the tools that we have. I think now it's becoming more and more prevalent in our societies. And I think more attention is paid to HCM. And so I think we're very lucky to have a bunch of resources. We have posters, we have webinars, we have lectures, we have so many resources now that we may not have had 10, 20 years ago. So I think that's a really great advice too, is to take advantage of all of those resources you have. You may not be lucky enough to have an educator in your small lab or a doctor that might feel like they're an expert. So I think even using some of those resources is a really nice way to sort of become more familiar with it.
Absolutely.
I think also I don't know for you, but I feel like breaking it down and not making it as complicated. It is complicated. It's a little challenging, obviously, but I think trying to make it as simple as possible. One thing I always say, and you've heard me say this before, Brad, is when we're getting measurements like the septum or LVEF, we're on axis. There's no question about it. You have to recognize what an on axis view looks like and be able to measure accurately. But when we're doing Doppler, when we're trying to get our LVOT gradients as high as we can, or trying to pull in MR, all those bets are off. So we go off axis as much as you can to align that Doppler, that cursor, with your LVOT gradient. So I think that's a really basic way to kind of teach it. There's a lot more into that, but I think if you can just say measurements, you have to be on axis and you have to know what that looks like. And then I think for Doppler, being able to say those are mostly going to be off axis views, trying to align your cursor best to pick up MR, to pick up your Doppler profiles.
Absolutely. Roll the patient, roll them back, roll them forward. Use your aortic stenosis skill sets you have. Come off those non-traditional views and try to use your imaging transducer in the right peristernal. Look down to see if you can see that gradient. Think outside the box. I think we are very routine in our what we do every single day. We do a lot of exams. We know it's busy. It's only getting busier. But think outside the box. Take the extra few minutes and roll that patient back and have them do a breath hold. Valsalva is really important in assessing these patients. Trying to provoke, is there an outflow gradient? So you're correct. We teach them to be exact every single measurement, but when you're dealing with HCM, you have to come out that traditional views and think outside the box.
Yeah, and you have so many folks that have this latent HCM where you can't really provoke, you don't see a gradient or an obstruction with LVOT until you do a provocation. So could you explain? You're really good at explaining this, and you've had a lot of experience with your goal-directed Valsalva. Can you explain what that entails and what that looks like for a sonographer and why we do it?
Correct. Yeah. So you mentioned before, asking 10 sonographers and a question, and one of those is, how do you perform Valsalva? And you'll get 12 different answers. And so one thing that we want to do is drive out variation. You want to have something that is consistent. And there's this great paper that was published a few years ago in JACE that was on Valsalva and how do you basically it tells you that you can use a sphygmomanometer and with a tubing. If you blow and hold to 40 for 10 seconds, you will get a good Valsalva maneuver out of that. We have taken that method and implemented it across our labs here. So it doesn't matter what sonographer you have or what machine, you're doing the same Valsalva, and then we report that out. The patient achieved 40 millimeters of mercury for 10 seconds, and the peak, gradient was this. That way, when they start their medication or if they're following this patient, we know what Valsalva was used. So we're being consistent in our process. We are able to determine what the gradient is, and that's through education and training, physician buy-in, showing it, plus it's supported by documentation that it has worked, and we have found great success with this method in our lab.
And how do you document that in your reporting?
So we have a finding code. We do write up our prelim reports for our physicians. So we just type that in there that what the patient was able to achieve, the millimeters of mercury. Let's say it's 40, they achieved 40. They don't need to go above 40. There's nothing that really supports going higher is not better. And then we document how many seconds they're able to obtain that for. The longer, the better the Valsalva. They'll need to go 20 seconds, but 10 was in the paper. So achieve 10 seconds at least. And then we document the peak gradient. And then, of course, we put what view in there. We encourage the sonographers to put what view did you get your highest gradient. It may be an apical 3 off axis view. It may be the right peristernal, so that the next sonographer at least has a way of knowing they got the gradient at this location, at this level, this time, so we can reproduce that.
Yeah, that view is so helpful. We don't do that, and I wish we did. I've sort of pushed for that because it is so helpful as the sonographer after coming behind you that to be able to know exactly where they located that Valsalva gradient. And I think, unlike you, I know you've been doing that a lot longer. We just recently implemented it within the last year of the goal-directed Valsalva. It's a standardized, effective, measurable method for us to be able to provoke LVOT gradients. And we've seen really great success with it. We've kind of done a pilot at first because they want to make sure that it works and kind of document that it's working. And we did our typical Valsalva that we all sort of have different explanations for, like you mentioned, versus that. And we definitely have seen with the data data that it's proven to be very successful. Again, very standardized, very measurable, in a very effective way to be able to provoke LVOT gradients. So I'm really excited about it. I think it's gaining more traction across the country. And there's some great literature on it. And I think there's also a video that's available going around that you could try to download or watch on the web that kind of gives you some insight on how to do that as well.
Yeah, but I think there's some new materials just came out in the last year on research on it that was presented at JACE, at the ASC conference at least. And so that showed how certain labs were showing great success with this. I think the main
That's
thing
great.
here is just being consistent. And we have seen where patients, when we have talked to them after the fact, they felt this was easier because it gave them something to look at. And they're blowing in a tube, so it kept them kind of busy off mind. But you tell them to blow, they can achieve it. Instead of tell them bear down, they're like, "What are you talking about?
Mhm.
Act like you've had a baby." Well, I'm a man. I don't have a baby, so I have no idea what that feels like. And so, so it just keeps things consistent. And again, eliminating any variations is always a good thing.
Yeah, and I love these HCM patients because I really want to do what's best. And so they want to do well and they want to do whatever you need them to do. So I think for you, like you mentioned, it's a great way for them to feel like they're participating and kind of actively helping you get the data that you need. So I think it's a great solution. And hopefully more and more centers start adopting that goal-directed Valsalva as well.
Absolutely. Yeah. So, what are you teaching your students? They're coming out. How are you getting them educated in this topic of all? There's so many pathologies in echo. This is just one. We need to be recognizing. How are you teaching that in your classes?
Yeah, that's a great question. It's a lot. It could be a little overwhelming for the students. I think it really helps that we see a lot of volume here at the Cleveland Clinic of patients. So as they're doing their clinical rotations, they're getting exposure. They're having a preceptorship, and that preceptor is explaining to them what they're doing step by step, trying to break it down as simple as possible. We also have a lot of lectures in class that kind of talk about it. But unless you're there and kind of hands on, which I think you and I both agree is the way to go when you're trying to teach people HCM,
Absolutely.
yeah, so I think they're lucky they get a lot of volume in their clinicals seeing these patients. But once they start in the real world and they've graduated and they're on their own or they're with somebody, we always make sure, at least here, that they have somebody that's going to be their mentor. So they have somebody that looks after all of their studies because it's really easy to miss some of these gradients, right? It's easy to miss LVOT if you don't do a great Valsalva. It's easy to confuse MR with LVOT gradients,
Yep.
intercavitary gradients. So there's a lot on there. So we try to make it as simple as possible, kind of saying we need this, and this, breaking it down. And then we definitely make sure that every study they do is supervised and looked over by a more senior sonographer that is a competent sonographer in HCM. And once they've done X amount of studies, we're very fortunate we have a simulator that has an HCM study that's downloaded on there. So that's a really nice way to kind of do a real life example. And be able to kind of mimic a patient without the pressure of having your patient there with you. And so that's some of the ways. I still think, 2, 3, 4 years in it, some people still don't feel very comfortable, which is understandable. I'm not sure if I was there yet either. So, just gradual and slowly getting them to feel more and more comfortable and explaining things as best you can. How about you guys?
Yeah, no, you hit it right. They come out of school knowing you hit the nail on the head. They learn so much, and it's going to be experience. We sit there, we teach them, we educate them. We are able to give them that one-on-one here. We do in Oklahoma. I cover the western 2/3 of the state, so I have sonographers in places where I am not physically with them. We give them the education. We do make trips out there. We review with them how to use the manometer and the method out there. We did our own video, so it's uploaded so they can watch it on how to use it as well.
That's great.
And so
Yeah.
we're trying to utilize technology to help. If we're not present with them, we're able to see in the PAC system as images are coming through. We can guide them and help them to obtain those. So a lot of one-on-one in the beginning, with our students as new grads, we give them hands-on. As they get more comfortable going forward, as they start recognizing the pathology, they're good about asking questions, which is great. They'll raise a hand and say, "Hey, I got this coming up. I think it may be a hypertrophic. Will you be around or somebody be around to help us?" And we'll make sure someone's around to help them.
That's great. That's really
Yeah.
nice. I was, now Mavacamten. I wanted to bring up Mavacamten, which is such a
Yeah,
game changer, right?
absolutely.
We hear all about it, and our sonographers, even the smaller centers, are now getting more and more patients that may have Mavacamten or Camzyos studies that are done. So I just kind of walk through what really we're looking for. Obviously, you're going to do full echoes at the beginning and sort of getting their baseline. But as you're walking through the Camzyos or mavacamten protocol, they're getting a lot of echoes, right? So we want to make sure we're giving them good echoes. And I'd be curious to hear what you do, but we typically are looking at the LV function. That's a huge for these mavacamten patients. This drug can have some adverse effects. One of them is dropping the EF and reducing that. So we always have to make sure that we're really on that and we're getting accurate measurements. So we've talked about just a minute ago about making sure you have an on-axis, non-foreshortened apical views. And those are what I always preach about, making sure you're getting a good biplane Simpson's EF. And that's a really critical role that we look at as they're giving their serial echoes with mavacamten. And then the other thing we look at, obviously, is the LVOT, right? We want to see, is there SAM? So we look at it in 2D. Is there SAM? Do we see any sort of SAM in the LVOT? That means that anterior mitral valve leaflet, typically anterior, will be sucked into that LVOT during systole. So that's the key, is it has to happen during systole. And we see if there's obstruction. Do we see it with 2D? Do we see it with color flow? Color flow Doppler, we would see it with aliasing velocities and different mosaic kind of look. And then your cursor through there with a continuous wave Doppler would tell us, is there velocities that look high that aren't your typical LVOT appearance or aortic valve appearance? And we can get into some of those and how you can tell the difference, but that's mostly what it is. And we do it by the 5-chamber view. We do that multiple times, different angles, kind of making sure we're lined up. And then we do it with a 3-chamber view as well. And we're doing it in both color, grayscale, looking at MR and doing the continuous wave Doppler. Is there anything else? And obviously for EF, if we need to add the ultrasound enhancement agent, that's definitely a go-to for the septal measurement and for the EF.
Correct. Yeah. So same thing. They're like, every 4 weeks getting their echoes. If it's been 6 months, we may check with the ordering physician to see if they want to complete the echo. Typically, the answer is no. Sometimes they're getting on other medications. They may have had a stent or something in the meantime as well. So we'll definitely search their chart out to make sure nothing really has changed. Just kind of check with the provider. You still want this as a complete. If it's order complete, we're checking with them. Why do you want to complete? A lot of times, like, no, limited's fine. But we definitely want to use the image enhancer in our lab and to ensure, because that EF is so important. You can easily overestimate or underestimate the EF just based on what you think you see. And you really got to see that compacted myocardium when you're tracing in your Simpsons and being on axis. So very important. But also the importance of getting your using your manometer method in our lab. Everybody's using that, so we're consistent, so we know what the gradient is. We're talking to our patients as well. Make sure they're getting enough volume intake. Because it's a very dynamic disease, and so make sure they're not drinking those caffeine drinks right after they come into us, and increase those gradients. But how are they feeling? Does the gradient, is it better? Is it worse? How are they feeling? But we want to make sure that we align that continuous wave Doppler and those off-axis images to not include MR, because contamination is the killer of this for sonographer. Is what is MR? What is outflow? How do you see the difference between the two? And so that's where that's what
Yeah,
we do.
that's a huge challenge for sure. And I
Yeah.
think when I try to help out some of these younger junior sonographers or just someone not as familiar with HCM, one tip I always give them is to try to, if you line up as lateral as you possibly can into your the Doppler into your LVOT, you can essentially eliminate the left atrium, and you wouldn't be detecting any MR mostly, in most cases. If you can line up and eliminate that LA completely from that continuous wave Doppler cursor, then you can essentially rule out whatever you're picking up is MR, because you're specifically through the LV, through the LVOT, through the aortic valve. So that's one tip that can help you in that and try to differentiate between MR and LVOT. If you eliminate the chance of MR being contaminating your continuous wave Doppler, then that helps you out a tremendous amount.
Absolutely. Yeah. But
Yeah.
so important. So important. And it's not always able to be achieved, that's what's challenging, but we got to try. And that's why it's important if you're able to get as a sonographer, document how you got that in the report, or somehow, and that the next following sonographer will know, where did you get this and how did you get it?
Yeah, that's great. And the MR, I think the other thing that's really confusing is trying to differentiate those Doppler signals. So I'm always teaching, and I'm sure you are as well, can you tell the difference between MR versus intercavitary gradient versus LVOT dynamic gradient versus aortic valve? And I think it's really important to have a visual. I always have a slide that I use as sort of a reference, but if you can like kind of picture in your head here. So if you have your MR continuous wave Doppler, it's most likely, this is generally speaking, is going to be a parabolic shape. It's going to be kind of a U-shaped. It begins a little bit earlier in the IVCT, and you typically have higher velocities. That's not always, but that generally speaking, you'll have a higher velocity somewhere around 6 meters per second. Of course, you can have an LVOT dynamic gradient the same, but that's a little bit more unusual. And when you look at your dynamic LVOT velocity, it starts off a little bit later. It tends to be more dagger shaped. So it's that late systolic peaking, mid to late systolic peaking look to it. And it just has a different look to it. Like I said, that dagger shape versus a parabolic shape and just the timing of it. So I think it's really important to be able to detect the two. Sometimes they're superimposed on each other, which can be a little bit tricky. You might see MR starting, and then as you get to the bottom of that Doppler jet, and that profile, you see that like that LVOT is sort of hidden behind it. So that's a little tricky. But again, if you try to use that tip where you go more lateral and line up, hopefully you can eliminate some of that MR. The other thing I think that gets confusing is that intercavitary gradient. So intercavitary gradient is caused by usually hyperdynamic, dry, smaller LV size. So I think using color is a big tip for that. We both have said to other folks, if you put a big color box on that LV, you could then visually see with your color box the level of obstruction where it starts. If you see really high aliasing flows in the middle of the LV cavity, those are most likely going to result in an intercavitary gradient, which may look suspicious like it's LVOT, but it's not. So it has a little bit different look to it. It's later peaking. It's kind of a little bit more narrow as it's the late systolic peaking, and it has a concave look to the profile. So I think those tips using color as your guide to kind of visually see where you see the obstruction. You could have both intercavitary and LVOT. That's not uncommon. But if you can use your color guide first as a big box in that LVOT and the LV to kind of see where the level of obstruction seems to be. And then again, you use that cursor. You can use your pulse wave cursor to kind of go from your apex to your mid and to your LVOT. And if you see that kind of late systolic peaking dagger shape, that's most likely where the obstruction is happening.
Very good. Yeah, we do the same thing. We start in apex, especially if it's a hard image. Your pulse wave is going to do well. Start in apex, and we just walk it down and to see if we can pick up a gradient, especially if we see a color flash or some type of high gradient in there. So that's a very good point in seeing that. Question that gets often brought up in my lab is, when we have those maybe apical HCMs or maybe a mid-apical hypertrophic disease going on, you get those high gradients, you get that lobster claw up there, and you have that mid-systolic break in between, and so they'll say, well, which do you measure to the left or do you measure to the right? Which one do you measure? And I say measure the highest and report out the highest. That's what we should
I
do.
say the same.
And
Yep.
so I get that question quite a bit. And they're like, well, last time they measured the first one, to this time, the last one. I'm like, to measure the last one, and
Yeah,
we don't
whatever's highest.
care, just measure the highest. And so I don't know if you come across
Yeah.
that in your lab or not. And so
I have. So how do you approach apical HCM? That's a kind of a different animal, right? It's a different way that you would approach that versus
yeah.
our typical LVOT obstruction. So what's your methodology, or how do your sonographers approach an apical HCM case?
So there's a case that I show here often. It's an echo was performed at a place where we didn't have image enhancer. It's one of our rural locations. We didn't have the physicians on site. And so sonographer thought they couldn't get the LV apex on axis. So it looked like it was foreshortened, and they kind of wrote it off as well, foreshortened. I really can't get it on axis. And that's hard sometimes. We always can't get our views on axis. And thankfully, the physician had an EKG that was done as well, and they saw some abnormalities that kind of looked like maybe HCM on there. And so they brought the patient back in for image enhancer use. And so we brought the patient in for a limited echo to use that. And sure enough, they had HCM. So it tricked the eye of the sonographer thinking that foreshortened, I can't get on axis. And there's really no color flow up there. I looked at the images. They did put the color Doppler up there. Wasn't anything that showed, something like maybe a narrowing or maybe like a little high gradient. And so she truly did have HCM. Thankfully, the EKG did pick it up, which then the physician went ahead and ordered it. This is not always shown on EKG. This is what's so tricky
Yeah.
about this disease. It's not always well represented in any one imaging modality. That's why it's hard to diagnose.
Yeah,
So
I
definitely
think of that
really
like ace
something.
of spades, right? Like the ace of spades figure,
Ace
if we
of
talk
spades.
about like,
Yeah,
yeah, where it's like that focal hypertrophy up at the apex. Now, it could continue on into the septum, right? Where you could have LVOT obstruction. It's not super common, I think, to have both, but you can sure have that as well. But yeah,
yeah,
the ace of spades is what I kind of try to tell folks and kind of visualize that, where it's this really thick area. And we're always concerned for like akinesis up there for aneurysms. So that's what you
absolutely.
mentioned. Yeah, that apex is so important. And I think if they're tough images, that ultrasound enhancement is so important. And even like scanning in the short axis, I think a lot of people forget about that, to go as low as you can in the short axis apex,
Yeah,
right? Because most people just kind of go to the papillary muscles and maybe go just a millimeter or two below that and, oh, I'm done. I have my apex. But really we physically slide a lot of times down to the very low apex, almost into like the apical window, to make sure we're getting the very, very, very tippy top of that apex. So I think that's another key to make sure you don't miss something.
absolutely. Because the first time you really see apex in most echo protocols is when you do your short axis view, the LV. And a lot of people do. They stop right, but get the papillary muscles. We can
Hmm.
see where the paps are inserting, kind of come down a millimeter or two, and we call it good. Really need to
Yeah.
sweep all the way through, completely out of the epicardium and make sure there's not a little aneurysm sticking out there.
Yeah. What are some tips you have? I know like one of the challenges that we have is for the septal measurement. So that's obviously super important and really relevant for these patients to see the thickness of that septum. So do you have any tips on how to get a good septal measurement?
So we want to be consistent in our lab, like you said, to get on point, get on axis with your images and with your measurement to be consistent. Always then measure the thickest part of the septum. However, be cautious and don't include the paraseptal structures. That's your RV trabeculations, some moderator bands, maybe, a RV papillary muscle that can easily trick the eye and lay on top of the septum. So I encourage my team to go into a short axis and to make sure there's not an RV structure that is mimicking a thick septum. That's probably the number one mismeasurement we see is the septum being overestimated on
Mhm.
routine examinations. When you do find a very thick septum, just show the doctor. Most of our equipment have 3D now, and so you have the X-plane ability. So show them side by side views and where you're measuring at, and do it in the long and short axis. But report out the thickest part of the septum on your report where it is. So we know going forward if it's getting worse or not.
Yeah, that short axis view I think is often overlooked. We think about parasternal long and that's all we go for. And then obviously just making sure that's a good on axis view because it's a measurement. So when you're, in most folks, we can get a good on axis view. There are some challenges in others, but you don't want to see an apex for a parasternal long view. That means you're down too low of a window. Your mitral valve and aortic valve should be sort of centered. So those are some keys I think you need to when you're scanning these patients and measuring, you got to make sure you're doing just the very basic techniques that we learned in school that often we sort of forget about or overlook, I think is so important for these patients.
I think something else that gets overlooked is a proximal septal thickening.
Mm.
We see those typically in the elderly, especially elderly women. We get that little proximal septal thickening. People just assume it's normal anatomy for age driven. Provoke that. There may be an outflow obstruction. Especially those little older patients, they become dehydrated, so they may get symptomatic from those. So, make sure you're looking at that closely. It can cause symptoms of obstructive hypertrophic. We have found a few in our lab here. The septum was normal till you got to the proximal septal, which was thickened, and we provoked a gradient.
That's awesome. Yeah, I feel like we're seeing more and more of the non-traditional sort of obstruction cases. So we see, I feel like a good amount now of the non-hypertrophic variants, I guess you could say, where they have unusual mitral valve leaflets. They're super long, or they have redundant mitral valve chordae that are, or something, or like a papillary muscle that's inserted apically. Or so there's all
Correct.
kinds of different variations that, we often think about. In most cases, are a big thick septum or some part of the heart, but there's also these kind of non-hypertrophic variations that are in this little basket over here that you just got to be aware of as well. So if you see something that looks like it wants to move towards the septum as they're in systole, I would, like you said, I would go ahead and do a good Valsalva with them, even a goal-directed Valsalva as well.
So as we wrap up here, what give three key points you'd give a sonographer for diagnosing, or just I guess cheer them on how to try
Yeah.
to find this disease?
Yeah. I would say, sort of like you mentioned earlier, number one, use your resources. So if you're lucky enough, you have an educator in your place, you have a staff that is well read in HCM and is able to diagnose and help you out with some of the technical aspects. Use the webinars, use the posters. There's a lot of literature out there now that helps step-by-step guide. Jace has a great article from Carol Mitchell and others that it's like a step-by-step approach and framework for a good echo, an HCM echo. So I would say, one, use your resources. Two, I would say, like I mentioned earlier, I always say on-axis for measurement. So on-axis imaging for your septal measurement, on-axis imaging for your EF, your biplane EF, and then off-axis for your Doppler. So if you're lucky, you get them all on axis and it's easy, but most of the time you're going to have to go off-axis to line up your Doppler appropriately. So know that that's okay and that's expected for either MR or for your Doppler as well. And number three, I would say don't give up. There's a lot of people that get frustrated and say, I quit, like I don't know how to do this, or I just kind of shut down. And I would say just keep approaching it, keep learning something new every time you do it. I still learn something new. There's always something new to learn with HCM. And I think just try to pick up as much and absorb as much information as you can from hopefully somebody that can mentor you at your facility or anywhere else you may do some research. But I would just try to pick up something new and don't give up. And eventually it will click, I promise. It might take a couple of years, it might take a couple of months. But if you do enough of these patients, that it will click eventually. And it's fun. Like I used to be like, not sure about HCM patients, but now it's my favorite thing. I think it's a great population. The patients are so grateful. And I think it's just kind of a good challenge to scan.
Completely agree. The only thing I was going to add is I know that things are busier. We seem to be doing more and more exams. Just don't rush. Do take the time on every echo, but these, and try to minimize variation in your lab. Maybe standardize a Valsalva in your lab. Use the tools in your tool belt. Use your ultrasound image enhancer agents that are out there. To ensure that we're doing the right things, and talk to your patients. Get a good history from them. Just ask them what's going on. Because we're trying to uncover. Once we find it, it's easy to see it. It's the ones that we're trying to uncover that are undiagnosed out there that, what may be going on with them. So,
Absolutely.
And we're here for resources as well. If you don't have an educator, there are a lot of resources. American Society of Echo webpage. There's a lot of free material out there to be had, to be read. There's someone close by, I promise, if you're listening to this, that will be willing to help you. If not, reach out to me.
Absolutely. I said Brad and I know are always offering that as well. Yep.
Yep, we'll be here to help. So that's all I have.
Yeah, I hope you all enjoyed it and you found it helpful. It gives you a little bit more courage to approach your next HCM patient.
All right, till next time. Good seeing you, Amy.
Bye.
That was Dr. Amy Dillenbeck and Dr. Brad Mehl. To learn more about the HCM Society, please visit hcmsociety.org. This episode was edited and produced by Earfluence. Thanks for listening, and we'll talk to you soon on In the Thick of It.